Hello everyone, my name is Badejoko of the Obafemi Awolowo University and its Teaching Hospitals Complex here in Ile-Ife, Osun State, Southwest Nigeria. Today I'll be presenting our work titled A Laparoscopic Surgeon's Learning Curve and the Trend of Minimal Access Gynecology in a Semi-Urban Teaching Hospital in Southwestern Nigeria. I bring you warm greetings from Great Ife, arguably Africa's most beautiful campus and its teaching hospital where this work was done. I will start by stating that I have no conflicts of interest to declare. The concept of learning curve was first put forward in the aircraft manufacturing industry in 1936 by T.P. Wright, and what Wright described was a basic theory of improved costing and productivity of the production of airplane assemblies when the workers were more experienced. The term was introduced to medicine in the 1980s with the advent of video-assisted laparoscopy and therefore laparoscopic surgery. It also caught the attention of the general public and in particular the legal profession when a GMC panel of inquiry in the UK was told by a pediatric surgeon facing the panel that it was inevitable that a high mortality rate would be observed in surgeons who were still on the learning curve. Now, when learning a new procedure, performance tends to improve with experience, and graphically plotting this performance against experience produces the learning curve. Clinicians who are less experienced in a procedure are said to be at an early phase on their learning curve, and improvements would be expected with increasing experience as they go along the learning curve. Now, the assessment of the learning curve would take into consideration the complexity or the level of difficulty of the task that is being completed, as well as the complications that are recorded in the process of these procedures. Using the Royal College RCOG guideline on classification of minimal access surgery or laparoscopic surgeries in gynecology, laparoscopic surgeries are divided into 3 levels. Level 1 comprising of simple diagnostic laparoscopy and tubal sterilization. Level 2 encompassing intermediate procedures like simple adhesiolisis, ectopic pregnancy, ovarian cysts, simple ovarian cysts, and mild to moderate or grade 1 and grade 2 endometriosis, whereas level 3 refers to those procedures like major adhesiolisis, grades 3 and 4 endometriosis, the various types of laparoscopic hysterectomy, myomectomy, and laparoscopic sacropexies. In Nigeria, laparoscopy first became available in the 1970s and was mainly used for diagnostic purposes and also for quite a few tubal sterilizations. The practice, however, declined over the next 3 decades as the infrastructure in the various government hospitals underwent a lot of decay due to neglect. However, the practice did not fizzle out in the country entirely because colleagues in private hospitals kept laparoscopy in their practice. The Obafemi Awolowo University Teaching Hospital complex in 2010 was one of the hospitals that benefited from the VAMED intervention of the then President Obasanjo administration, and with that came the supply of basic video-assisted laparoscopy equipment to the hospital, and we, for the first time, were able to start performing laparoscopic surgeries in gynecology in 2012 after the delivery of the project. We therefore designed this study with the objective of evaluating the relationship between the learning curve of a minimal access gynecologist in OATHC Ile-Ife and the trend and outcome of minimal access gynecology procedures in the institution. Our specific objectives were to compare the minimal access gynae surgeon's learning curve with respect to proportion of major procedures performed, the rate of conversion to laparotomy, as well as the rate of minor and major complications, including mortality. Our methods, we designed this study to be a prospective observational analytical study, and inclusion criteria were all laparoscopies performed by this author in OATHC between April 2012 and March 2020. We excluded all laparoscopies that were performed by other surgeons apart from the author. Laparoscopies that were done outside the period of this study were also excluded, as well as laparoscopies done by the author but outside the study location. Our study procedure entailed data collection prospectively at each laparoscopic surgical procedure by the author. The instrument was a purpose-designed proforma for prospective data collection. Our statistical analysis entailed grading of all of the various laparoscopy procedures into L1, L2, and L3 in line with the RCOG classification, and we then performed a time trend analysis from 2012 to 2020 on the annual proportions of levels 1 to 3 procedures using the Mann-Kendall test. The level of significance was set at p less than 0.05. Our findings showed that a total of 217 minimal access gynecology procedures were performed over this study period, which comprised of 46 L1 procedures, 152 L2 procedures, and 19 L3 procedures, each accounting for 21% L1, 70% level 2, and 9% level 3, respectively. The level 3 procedures that were performed included 6 laparoscopic hysterectomies, which were made up of 5 total laparoscopic hysterectomies and 1 laparoscopically assisted vaginal hysterectomy, 6 grade 3 to 4 endometriosis surgeries, 2 laparoscopic retrievals of perforated intrauterine contraceptive devices, 1 laparoscopic myomectomy, a laparoscopic cystectomy of a large dermoid, a laparoscopic management of huge endometrioma, a sapingectomy for heterotopic pregnancy in the second trimester, and a laparoscopic resection of a cornual ectopic pregnancy. Our trend analysis revealed that we did the most procedures in 2012, and there appeared to be a progressive decline in the number of procedures up until 2016, and this is largely attributable to a lot of instability occasioned by professional disputes, strike actions in the health sector. Between August 2016 and August 2018, the author took a study leave and so was away, and that explains why there was no procedure recorded in 2017. And then procedures resumed again in August 2018, all of 2019, and the first quarter of 2020. Now, what is striking from this is the fact that looking at levels 1, 2, and 3 procedures, level 1 at the bottom in the light blue, level 2 in the dark blue, and level 3 in the orange color, you would observe that year on year there appeared to be an increase in the proportions of levels 2 and 3 procedures compared to level 1. So level 1 procedures were reducing and levels 2 and 3 procedures were increasing in proportions as time progressed. Very importantly, we looked at the first 2 years of this learning curve and looking at the levels 1, 2, and 3 procedures, and this was what has been described was confirmed in the trend plot that is shown here, where you would observe a reversal of the ratios of levels 1 compared to 2 and 3 procedure between 2012 and 2013, suggesting that more advanced procedures were being added on as time progressed along the learning curve. So although the proportion of level 2 and level 3 procedures increased while level 1 reduced, the difference here was not statistically significant. And I think this is important because it shows that the slope of the learning curve was quite gentle. In other words, advanced procedures were not embarked upon prematurely. There was sufficient time allowed to gain sufficient experience with the simpler procedures before adding on advanced procedures. The first level 2 procedure, for instance, which was a laparoscopic ovarian cystectomy, was not performed until after 5 level 1 procedures had been done. Also, the first emergency level 3 procedure, which was the laparoscopic salpingectomy for a heterotopic pregnancy, was performed only after 28 level 1 and 2 procedures had been done. And indeed, the first total laparoscopic hysterectomy in my series was performed after 46 level 1 and 2 procedures. This just illustrates how gentle the slope was of this learning curve. Minor complications were recorded in the first year. In 2012, we had 2, one diathermy skin burn and one inferior epigastric vessel injury, which was managed with balloon tamponade from a Foley's catheter. We had 2 major complications, one left common iliac artery injury, which happened when a trainee was asked to pass a secondary port, the right iliac fossa secondary port, and they inadvertently injured the left common iliac artery. The second was a sigmoid colon injury, which was sustained during major adhesiolysis. There was no readmission and there was no mortality. There were 7 conversions in total, and again it will be noticed that the conversions occurred in the early phase of the learning curve. Between 2012 and 2014, 6 of the 7 occurred during that time frame. The one conversion that occurred in 2015 was indicated by a decision to proceed to a myomectomy in a patient who had gone in for laparoscopic tubal surgery. Also, it is interesting to note that some of these conversions were occasioned by equipment failures, as we would see as reflected in the 2013 light source failure and as well as the 2012 camera failure. So overall, we conclude from this study that careful attention to the learning curve is associated with the progressive attainment of advanced laparoscopic surgery skills, and therefore the successful establishment of an enduring minimal access gynecology service, even in a resource-constrained semi-urban setting as in Ile-Ife, Nigeria, where I practice. Here are some of my references. Thank you for your time.